Quick video to pick up where we left off in week 6. This material is testable material for your second midterm for pharmacology. This was required reading for week 6, and some of these medications we have talked about in earlier weeks, so there'll be a review, and some of these medications will be new. Want to stress that this video is not meant to replace reading your required chapters, completing the online testable practice questions that will help support your learning, and also not meant to replace attending class. Okay, so medications used to treat heart failure are a number of, and any one of these. So your patients could be on any one of these medications if they have a history or diagnosis of heart failure. They could be on one or more. And if we go up in one, we may go down on another, or we may go up in all of them, depending on the progression of your client's heart disease. So we've talked about ACE inhibitors, ARBs, and beta blockers in the past. The new medications that we're going to spend some time learning are vasodilators and the cardiac glycosides. And also, we'll review briefly diuretics. However, we've covered this in earlier weeks, so please refer to your notes. Again, we left off on slide 19, but I'm backing up to slide 13 just to support your learning. If you do have questions, please post these in the discussion board. Please help answer questions from other peers, and if you have an answer to someone's question, please provide the source. So ACE inhibitors, these are first-line medication often prescribed with clients that have a history of heart failure or high blood pressure, or who have had a heart attack. ACE inhibitor stands for angiotensin converting enzyme inhibitor. These medications commonly end with pril. So the example here that we're looking at is lisinopril, also known as Prinavil or Zestoril. The therapeutic actions here is that this medication lowers blood pressure, prevents high blood pressure by acting on the cardiovascular smooth muscle. You can read about that in your textbook in the pathophysiology. But this medication eliminates sodium, and whenever you eliminate sodium from the kidneys, water tends to follow. So by removing sodium in water, we therefore lower blood volume. If we lower blood volume, we lower blood pressure. One thing that I want to stress in this yellow box, we've talked about this a number of times, because this medication is used for high blood pressure to have the effect of causing we hope that it'll put our client into normotensive or normal blood pressure, but it could cause hypotension. So that's something that we watch out for as nurses. Therefore, if you don't have when you would hold this medication on your medication template, now would be a good time to write it in. You would hold this medication if your client's blood pressure was less than 100. You would also assess for kidney function and electrolyte imbalances. As we said, this medication eliminates sodium, so it could cause depletion of your sodium. Hope you know the nursing word for that. It may cause hyperkalemia. So by eliminating sodium, we may hold on to potassium. If we do that, there can be side effects that we want to watch out for there as well. So you should know the side effects of hyperkalemia. Stressing here down in the adverse effects, things that we watch out for. You'll notice clients may experience headache, dizziness, nausea, and vomiting. These could all be signs and symptoms that your client's blood pressure is already too low. So if your client experiences any of these, you'll want to check their blood pressure. You'll want to do a full set of vitals, but particularly you want to check their blood pressure and assess them for any hypotension. These could also be signs and symptoms of electrolyte imbalances, such as hyponatremia or hyperkalemia. Important points to help teach for your client is that this medication may take a few weeks, if not months, for it to reach its therapeutic effect. Clients may often expect their blood pressure to drop radically within a few days or a week. You'll have to remind them that this could take a few months for them to experience an overall gradual reduction in their blood pressure. By giving them that information, it'll help them maintain taking their medication and follow-up appointments to validate that their blood pressure is actually within normal limits and not too low. Also caution them that if they're going to start any over-the-counter medications, that they need to chat about this with their family doctor or the prescriber of this medication prior to doing so. ARBs, angiotensin II receptor blockers, are also very similar to ACE inhibitors. So if you look at these two slides, they're almost identical, except ARBs are less likely to cause hyperkalemia. But essentially you could group these medications together. So the example that we're looking here is candesartan or Atacand, again used for heart failure, hypertension. Very similar. We sometimes look at a client may be put on an ARB if they're not able to tolerate an ACE inhibitor. So again, just backing up. Sorry, I realized I jumped. If when we see the words ACE capitalized here, ACE, we talked about how that abbreviation might help us as nurses recognize the key signs and symptoms that we want to watch out for when a client takes this medication. Hopefully you're able to identify these. I'm not going to elaborate on them, but if you were in class, those were written in your notes. If you're not sure, then please post that as a discussion question for your peers and somebody will answer. Again, you can group angiotensin receptor blockers with ACE inhibitors. Very similar, we're going to hold if the blood pressure is too low or if they're experiencing any headache, dizziness, or signs and symptoms of hypotension. Again, teach them that they need to report those symptoms to their doctor. This could take weeks to months to experience the therapeutic effects. Moving forward. Beta blockers. This is another medication we've spent a lot of time talking about in class. These are the medications that end with laugh out loud or lull. They lower your heart rate and your blood pressure. So they work on heart failure by decreasing the cardiac workload. So they slow it down so it can't work too hard because working too hard is a danger. It causes the heart to get even larger and then fail even further. Much like your bicep, if you're flexing your bicep constantly or you're putting strain on it, it's going to grow. Your heart is under the same press. So if you strain your heart or cause it to work too hard, it will also get thicker. And unfortunately, that muscle, if it gets thicker, it becomes less effective. So please watch out for a low heart rate and blood pressure when delivering or administering this medication. You would hold this medication if the heart rate's less than 100, or if the blood pressure is less than 100 systolic, or if the client's complaining of any signs and symptoms of hypotension. Your heart rate normally varies between 60 and 100. You should know that parameter. However, you would want to report to the doctor immediately if the heart rate was below 50. This could be signs and symptoms of a heart block. And you want to teach your clients, it's bolded here, not to stop taking this medication abruptly. That would be very dangerous. All of these medications work on the heart. By stopping this medication abruptly, you could cause the heart to work too hard, too fast, and the clients could experience some significant worsening of their symptoms. So educate them that they should not stop taking the medication. Speaking of general health teaching when it comes to heart medications, clients should not skip a dose or miss a dose, and they should never double up on a dose if they miss a dose. So very important for them to take their dose at their regular scheduled time. Vasodilators, these are new medications that we have not talked about. So spend some time. Hopefully you've completed your medication template prior to watching this video. If not, I'd recommend that you pause this video, do the research using the template, and then watch this segment of the video. These play a minor role in heart failure, so you don't always see these prescribed, but they do. But quite often you will see them with a number of geriatric clients or clients that have a history of heart failure or hypertension, some that even have a history of angina or chest pain. Okay, so how they work. They reduce, again, the workload of the heart. They cause venous dilation or dilation of the venous or the arterial system. So they enlarge the heart vessel, or sorry, the cardiac smooth muscle. They enlarge your cardiovascular smooth muscles. So just look down here and in the corner, your normal blood vessel constricts and relax under an autonomic regulation, so no control over that. If we give a vasodilator, the lumen becomes much larger, thereby reducing the blood pressure. So if you have more room for the blood to move through, then the blood pressure will drop. If the blood pressure drops, that's actually a good thing. We want it to drop to normal or just under normal. We don't want it to be significantly low. So it's a delicate teeter-totter balancing act. That's why we watch our patients closely on these medications. By increasing the diameter of the arterioles, we will increase blood flow to the kidneys, which will also remove, as more blood flow through the kidneys, we will have more urine production, and when we have more urine production, we lose blood volume, etc. Things that we have to watch out for when we give a client a vasodilator: when you lower the blood pressure, your clients can experience a reflex tachycardia. So as you drop the blood pressure, the heart attempts to compensate by pumping faster. So your pulse will potentially elevate. So that's a concern for a nurse. If the blood pressure drops and the heart rate rises, that's a big concern. Why we have assessed lung sounds. You'll recall in class on the board, we drew the heart. We talked about the difference between right-sided and left-sided heart failure. Left-sided heart failure, which is the common one, blood backs up into the lungs. So if blood is backing up into the lungs, we typically hear crackles or fluid accumulation in the lungs. That can indicate the heart failure is getting worse and that the clients are experiencing difficulty breathing or exchanging oxygen. We also talked about right-sided heart failure, and the blood, if the right side of the heart backs up or does not pump properly, fluid will back up into the rest of the body, or the venous side. So we talked about abdominal swelling. Hopefully you remember the A word for abdominal swelling. We also talked about peripheral swelling of the feet, known as pedal edema. Very important to teach your clients that are on cardiac medications that they should weigh themselves daily. And they should be using the same scale. We stressed this in class. The same time of day, same amount of clothes, same scale, and that way they'll be able to best pick up whether or not they're having a significant weight gain or weight loss. If we have a significant weight gain, we're actually concerned that the medications may not be effective, or that the kidneys may be suffering some damage, or that the heart failure is actually getting worse. So very important that if your clients experience a weight gain of 1.5 kilos in a matter of 24 hours, that needs to be reported to their doctor. That could warrant further investigation, so they would need to be seen and assessed by their doctor. The other things that we have to teach our clients, we talked about nitro spray for angina in week 5. So we're back to the fact that this medication lowers blood pressure. So when you take other medications such as nitro spray or medications like Viagra for erectile dysfunction, serious episodes of hypotension can occur, and these can be life-threatening. So clients need to know this if they are taking this medication. And so these two medications wouldn't be mixed. If a client is on a vasodilator, they would not be prescribed Viagra. So again, stress the importance of the fact that orthostatic hypotension could occur and that they need to change their position slowly. We spent a significant amount of time talking about this in class, but your job as a nurse is to monitor their vital signs. So check their heart rate. You want to look out for that reflex tachycardia. Check their blood pressure. You want to make sure that they're not hypotensive. And if those vital signs are within normal limits, then you can go ahead and give this medication. Digoxin. If you've not spent any time prepping your medication template, please do so. Pause the video, look at your drug guidebook, and try to fill out the template. So the medication for cardiac glycoside that we're going to look at in closer detail is called digoxin, also known as Lanoxin. I'd like you to write at the top of this slide that this medication is extremely dangerous. It's dangerous because it has a very narrow therapeutic range. It is used with heart failure, and it's often used with some types of atrial dysrhythmias, such as atrial fibrillation. So your clients can be on this medication for more than one reason. I want to stress that if you look at the bottle here, the dose of medication is 125 micrograms. You'll remember how small that is, or also known as 0.125 milligrams. This is a very tiny pill with a very tiny dose, but is a very powerful medication with a very narrow therapeutic range. So there's the potential that clients could become toxic or subtherapeutic very quickly. If they're subtherapeutic, that is danger, because basically that means their heart failure could be getting worse. And if they're toxic above therapeutic levels, then they could experience severe bradycardia or life-threatening dysrhythmia, such as heart block. And clients can become toxic for a number of reasons, such as dehydration, hypokalemia, etc. So when your clients are on this medication, I'm going to stress, I'll just point out here at the top, one of your most important nursing actions prior to administering this medication, every nurse must take the apical pulse for a period of 60 seconds, one full minute. So normally we check the radial pulse before giving cardiac medications. In this situation, you're going to check the apical pulse for a full minute, and you should know how to landmark the apical pulse. What you're listening for is the rate. You're counting it for a full minute, and you're listening to the rhythm, then noting whether it's regular or irregular. So you would never give this medication without checking the apical pulse for a full 60 seconds. So in this case, you would not be taking the radial pulse for 15 seconds and multiplying it by 4, or taking it for 30 seconds and multiplying it 2. That would not be acceptable. That would be practice and very dangerous for your clients. You also have to teach your client at home that they need to monitor their pulse, so you're going to teach them how to monitor their pulse for a full minute prior to taking this medication every day. No shortcuts with this medication. Again, it is extremely dangerous. There are a number of drug-to-drug interactions that can occur and a number of reasons why your clients might become toxic. If they become toxic, this could be very dangerous and it could kill them. So you want to teach them to monitor their therapeutic levels by following up with their doctor at regular scheduled visits so they can have lab work done. The doctor will draw labs to determine that their DIG level is within normal limits and that it's not too high or not too low, because again, if it's too low, their heart failure could be progressively getting worse. Knowing the signs and symptoms of toxicity. There are early signs and there are late signs of DIG toxicity. So you as a nurse need to figure out the difference between early and late signs. So I'm going to ask you, if you don't already know them, to pause the video and attempt to learn the early and late signs, because they're crucial information for you as a nurse that if you're administering this medication. So go ahead, pause the video, try to fill in the early and late signs of DIG toxicity, and then come back to the video. All right, hopefully you've done that. Want to stress here that the early signs of DIG toxicity are nausea, vomiting, and loss of appetite. These are very vague general symptoms, and your clients may overlook them and may just push through, but this is a warning sign that might be helpful. If they recognize that nausea, vomiting, and loss of appetite are signs of toxicity or early signs of DIG toxicity, they can go and have their levels checked. And if they don't, they could progress into the late signs of DIG toxicity. And what I want to stress here is that, that you might experience visual disturbances with DIG toxicity. Clients will usually report a green or yellow visual disturbance, so they'll have a hazy green or yellow visual disturbance, and perhaps a halo effect when they look at lights. So they might see a ring around the light, and if they report any of this to you, it's full information. Your doctor needs to be assessing their lab levels for DIG toxicity. If they are in fact DIG toxic, if the lab report comes back indicating that they've overdosed on digoxin, which could happen unintentionally with things like hypokalemia or low potassium, the doctor may just hold the medication, or they may determine that the heart is slowed down too much and they need to in fact administer the antidote. So the doctor may just hold the medication and allow the DIG to eliminate itself from the body. But if it's too severe and they're experiencing severe bradycardia, they might administer an antidote called Digibind or digoxin Immunofab. So again, as a nurse, I want to stress, you need to take the apical pulse. For how long? Good. Also, you want to monitor their renal function. Again, kidneys are very important to the elimination of this medication. If your clients are reporting a weight gain, that could indicate that the heart failure is getting worse or that their kidneys are not functioning properly. So how are you going to teach your clients to record their weight or monitor their weight? If you don't come up with an answer, I'd like you to review the book. Also monitor for drug-to-drug interactions. So caution your clients on antidiarrheals and antacids. This may make this medication less therapeutic. Or it could cause hypokalemia. And if it does cause hypokalemia, your clients are at risk of developing DIG toxicity. So you want to teach your clients that they need to eat diet high in potassium-rich foods. Hopefully you're able to identify some of those. So know the signs and symptoms of early and late digoxin toxicity, monitor the apical pulse for a full minute, report any weight gain why, and then eat potassium-rich foods why. Hopefully you walked away from or able to fill that out on your template. The next drug that I'm not going to cover is the loop diuretic Lasix. This is another medication that's commonly prescribed for heart failure. Please refer to your notes from week 5. The only thing that I'll add that won't be tested, but for the sake of clinical practice, if your client does have an indwelling Foley catheter, you should empty that when you administer Lasix. So that should be emptied if you're in an acute care setting, so that any new urinary output can be recorded and monitored there. Also, again, just stressing the importance of monitoring kidney function, daily weights, and the vital signs that you need to monitor prior to giving a diuretic. Hopefully you have those written on your template. If not, please ask questions on the discussion board. Overall, the nursing process for clients that have a history of heart failure, or we want to prevent the heart failure from getting worse, whether it be left-sided or right-sided, they're going to be making some lifestyle changes, and they may require medications, one or more from any of these categories that we've just talked about. The goal is that the cardiac output or the blood pressure remains within normal limits or on the lower side of normal limits, because we want the heart to rest. We don't want it to work hard, because that makes the heart failure worse. Clients should understand the reason for taking their medications. They should also understand what signs and symptoms that indicate they need to be evaluated by their doctor. They should know how to check their daily weight. They should know that they need to maintain follow-up doctor's appointments, and potentially the doctor might order an EKG lab work to determine if their medication is working appropriately. If they have any palpitations, that should be reported to their doctor immediately. They should be checking their pulse prior to taking certain medications. So hopefully you've identified those. I'm going to move forward. The next slide, nursing process overall, very similar for angina, myocardial infarction, and CVA, also known as cerebrovascular accident or brain attack or stroke. Again, any one of these medications can be prescribed for angina, heart attack, or stroke. So you want to become very familiar. Cardiovascular disease, heart attack, and stroke are very common in our population and in our Western population, and more prevalent in certain categories of demographics. So you'll want to become very familiar with these. I'm going to stop there and create another video for the following components. If you had questions watching this video, again, please refer to your textbook or your chapter. If that doesn't provide you with the answer that you're looking for, please post a question on the course discussion board, and hopefully one of your peers will answer it. And if they do, indicate whether they have the right answer or the wrong answer. Also, if you do provide a rationale or an answer to someone's question, please provide the source where you found the information. That's also very helpful. Thanks so much, and watch the rest of the videos. Just stressing, these videos are not to replace your reading. These are not enough to do well on the test.